Usually when we talk about a medical diagnosis, there is this expectation of precision. Like if you break your arm, the x-ray shows a jagged white line, right?
Right, yeah. And the doctor just points at it and says, there it is. That's the problem.
Exactly. And it's a very comforting way to view medicine.
It really is. We naturally want our ailments to be visible, localized, and just easy to categorize.
But then you step into the world of chronic pain or autoimmune conditions, and suddenly that x-ray machine feels completely useless.
Yeah.
You're looking at a diagnostic landscape that is incredibly murky.
Oh, murky is the perfect word for it. It's frustrating for the patient and the clinician.
Absolutely. So welcome to you, our resident learner, to another deep dive. Today we are exploring a medical mystery that sounds incredibly specific, but the lessons it holds about how the human body operates are universally fascinating.
They really are.
We are investigating a direct clinical correlation between a chronic skin condition called lichen sclerosus, or LS, and a deeper systemic muscular issue known as hypertonic pelvic floor dysfunction.
It is a remarkable intersection. I mean, we are looking at two entirely different systems of the body. The integumentary system, which is the skin,
Right.
and the musculoskeletal system. And they're colliding in a way that modern medicine is really just beginning to fully appreciate.
To guide us through this, we are pulling from a really robust stack of clinical material. We have the UK National Guidelines from the British Association of Dermatologists. We've got clinical overviews from the Proactive Pelvic Health Center, and some vital patient advocacy resources from the Lichen Sclerosis Support Network.
And that patient perspective is so crucial here.
It really is. Because people living with these conditions, they often highlight these hidden connections years before the clinical data catches up to them,
Yeah, they're the ones actually living in that body, experiencing the overlap firsthand.
Exactly. And that leads to our primary focus for today. At first glance, dermatology and pelvic floor mechanics seem like entirely separate medical silos. But we're going to reveal how a surface-level irritation can completely rewire deep muscle behavior, creating this hidden cascade of symptoms.
It's a domino effect, really.
Okay, let's unpack this. Before we can really grasp how these two systems interact, we need to establish exactly what these conditions are, starting with lichen sclerosus. According to the dermatological guidelines, this is a very aggressive chronic condition.
It is. It's a chronic T-cell-mediated inflammatory dermatosis.
Okay, that's a mouthful.
I know. To break that down, we need to look at the immune system. T-cells are essentially the body's foot soldiers.
Right, the frontline defense.
Exactly. Their job is to identify foreign invaders, like viruses or bacteria, and destroy them. But in an autoimmune condition like lichen sclerosus, those T-cells get confused. They misidentify the body's own healthy tissue as a threat and launch a localized attack.
And the research points to a very specific target for that attack, right? Something called extracellular matrix protein 1.
Yes. There is very compelling evidence of autoantibodies forming against extracellular matrix protein 1. Think of this protein as the biological glue.
Like the scaffolding.
Basically, yeah. It holds the different layers of the skin together and gives it structural integrity. So when the immune system attacks that specific protein, the skin physically breaks down.
And this primarily affects a very specific area.
Right. It primarily affects the anogenital region. So the vulva, the perineum, and the perianal area in women, though I should mention it certainly affects men and children as well.
The symptoms described in the clinical literature, they sound genuinely debilitating. Patients deal with an intense, unremitting itch that, doesn't respond to normal soothing creams.
No, standard moisturizers do absolutely nothing for it.
Right. And severe burning and very distinct structural changes. The skin becomes incredibly thin and fragile. You see pale, atrophic areas, and very commonly, this characteristic figure of 8 white patch that encircles both the vulva and the anus.
Yeah, and beyond just the visual changes, the loss of architectural integrity is what makes progressive LS so difficult to manage.
What do you mean by architectural integrity?
Well, the labia minora can literally resorb. They essentially fuse into the labia majora. The clitoral hood can scar and seal completely shut, burying the clitoris, which is a condition known as clitoral phimosis.
Wow.
Because that biological glue we talked about is being destroyed, the skin loses all its elasticity. Normal, everyday friction causes painful tearing or fissures.
So we have a surface landscape that is inflamed, it's scarring, and intensely painful. Now let's look at the second piece of this puzzle, the pelvic floor.
Okay, so the pelvic floor is a complex hammock of muscles, ligaments, and connective tissue. If you visualize the human pelvis, this muscular hammock attaches from the base of the spine, the tailbone, and sweeps all the way forward to attach to the pubic bone in the front.
It essentially acts as the foundational support system for the entire pelvic cavity.
It really does the heavy lifting. It supports the pelvic organs, the bladder, the uterus, and the bowel. And these muscles, they have to be incredibly dynamic.
Meaning they can't just be rigid.
Exactly. They must contract to maintain continence,
Hmm.
literally keeping urine and feces inside the body. But they also must be able to completely, consciously relax to allow for urination, bowel movements, and sexual intercourse.
Okay, I am trying to visualize how these two interact. Let's say the pelvic floor is the foundational support beam of a house.
I like that.
Lichen sclerosus is like a localized issue happening with the drywall or the exterior paint right on the surface. Now, the dermatological guidelines are very explicit that LS never affects the internal vaginal mucosa. It stops right at the mucocutaneous junction.
Which is the exact border where the external skin meets the internal mucous membrane. Much like the edge of your lips on your face, the disease strictly stays on the outside.
Right. So if the disease process stops at that border and never penetrates inside, why would the internal structural beams, the pelvic floor muscles, be impacted at all? If the surface drywall is peeling, the foundation of the house shouldn't warp.
That perceived boundary is exactly what kept these two conditions in separate medical silos for decades.
Oh, really?
Yeah, because the correlation isn't anatomical. It isn't the skin disease physically spreading into the muscle tissue. The connection is neurological, and it relies heavily on the central nervous system. It's all about the human body's prime directive, which is defense.
So the body is actively reacting to the threat on the surface.
Think about the physical proximity. The vulval skin lies directly over those pelvic floor muscles. When a person experiences the severe chronic pain, the tearing, or the maddening itching of LS, the central nervous system registers a massive localized threat.
It's setting off the alarm bells.
Exactly. And muscles have a very specific autonomic reflex when the tissue right on top of them is being damaged. They guard.
Like flinching if you touch a hot stove.
Exactly like that.
Yeah.
If you touch something hot, your bicep violently contracts to pull your hand away before you even have time to consciously think about it.
Right, it's instantaneous.
But with lichen sclerosus, the hot stove is constant. It never goes away. So those dynamic pelvic floor muscles chronically contract to guard and protect the inflamed, painful tissue sitting right above them.
Here's where it gets really interesting. In the clinical overview from the Oxford University hospitals, they highlight a physiological response that takes this beyond just a reaction to active pain.
Oh,
The pelvic floor muscles don't just tighten when the skin is touched or actively tearing.
right.
They actually tighten in response to the anticipation of pain. Just the anxiety about potential discomfort causes the muscles to clench.
What's fascinating here is how the brain's attempt to protect the body eventually becomes its own pathology. Because this chronic guarding, it doesn't just switch off when the patient goes to sleep.
Oh, wow. So they're clenching all night.
Over months or years of living with untreated or poorly controlled LS, the nervous system keeps those muscles locked in a state of high alert. They literally forget how to relax. They become overactive, shortened, and constantly tense. This is the definition of a hypertonic pelvic floor.
Hypertonic meaning there's simply too much tone in the muscle at rest.
Yes. And muscle physiology tells us that a muscle cannot stay contracted indefinitely without consequences. When a muscle is locked in a spasm, it becomes exhausted. Cellular waste products, like lactic acid, build up rapidly.
Sort of like after a really intense workout, but nonstop.
Right, and then the tissue develops trigger points, which are hard, hypersensitive knots within the muscle fibers. Furthermore, a permanently contracted muscle literally squeezes its own blood supply shut.
Which means it's not getting oxygen.
Exactly, leading to a drop in oxygen reaching the tissue.
So the defense mechanism, the guarding, creates a secondary source of severe pain deep within the pelvis.
It creates a massive secondary pain generator. And understanding this physiology completely solves a major clinical mystery that has frustrated dermatologists for years.
The secondary sensory problem. I read about this in the guidelines, and it sounds incredibly disheartening for the patient. A dermatologist will treat the lichen sclerosus successfully, right? The local immune response is suppressed, the architectural scarring is halted, the erosions are completely healed.
The skin looks great.
Clinically speaking, the surface skin is in remission. but the patient is sitting in the office in agonizing pain.
Right. The surface drywall is patched, but the foundational beams are still locked in an emergency lockdown. The original flood is gone, but the central nervous system hasn't sent the all-clear signal to the pelvic floor.
So the patient is dealing with the aftermath of the guarding.
This is where we see diagnoses like vaginismus, which is the involuntary painful spasm of the vaginal muscles, or provoked vulvodynia, which is severe nerve pain triggered by touch.
Even after the skin is healed.
Even after. The patient experiences tearing, burning pain during intercourse, or even just sitting down for a long time. Not because the skin is currently diseased or inflamed, but because the hypertonic muscles underneath are acting like a rigid brick wall. The tissue can't yield.
Which brings us to the disastrous domino effect this has on a person's life. Because a hypertonic pelvic floor doesn't just cause localized pain, it disrupts that entire foundational support system. It affects the bladder and the bowel.
Oh, heavily.
And the sources from the Women's Health Clinic point out a really difficult diagnostic trap here. They call it the masking of true laxity.
It's a very counterintuitive presentation. A patient will often go to a clinic complaining of looseness. They might feel a heaviness in their pelvis or feel like their internal organs are dropping, which are classic symptoms of pelvic organ prolapse or muscle weakness.
Right.
But upon examination, the clinic finds that the patient actually has a severely overactive hypertonic pelvic floor.
How does a muscle that is too tight feel loose to the patient? I mean, that sounds backwards.
It does. It's because of profound fatigue. Those muscles have been clamped shut, guarding against the lichen sclerosus pain for so long that they are completely exhausted. They have no strength left to support the organs.
So they're just giving up.
So they feel weak, heavy, and loose to the patient, but they are actually functionally exhausted from being locked in a spasm.
If a clinician takes that complaint at face value, assumes the muscles are just weak from aging or childbirth, and tells the patient to start doing strengthening exercises, that is a recipe for disaster.
It's the exact opposite of what they need.
And this leads us directly into the vicious cycle of this dual diagnosis. Because the hypertonic pelvic floor isn't just a lingering side effect. It actually turns around and makes the lichen sclerosus worse.
If we connect this to the bigger picture of daily bodily functions, a muscle that is already fully contracted cannot do its job properly. It cannot contract further to hold back urine when a patient sneezes or coughs.
Because it's already maxed out.
Right. And it cannot consciously relax to allow the bladder or bowel to empty fully.
So the patient starts developing functional issues. Urinary frequency, urinary urgency, or, difficulty fully emptying the bladder. They might develop chronic constipation because the pelvic floor simply won't release to allow a bowel movement.
And this creates an incredibly hostile environment for the surface skin.
It's somewhat like clenching your jaw because you have a severe toothache. You subconsciously clench for 3 days to brace against the nerve pain.
That's a great way to put it.
And the next thing you know, the tension in your jaw gives you a blinding tension migraine. The toothache caused the migraine. But in the case of LS in the pelvic floor, the migraine actively makes the toothache worse.
Exactly. The clinical literature points out that the urinary or fecal incontinence caused by these exhausted, tight muscles means that microscopic amounts of urine and feces are now frequently exposed to the vulval skin.
And we know that urine is incredibly acidic. It's irritating to perfectly healthy skin. Exposing fragile, compromised, inflamed, lichen sclerosus tissue to urine is like pouring salt on a wound.
No, it's agonizing.
So let me get this straight. The tight muscles cause the leakage. The acidic leakage burns the fragile skin. The skin flares up with intense LS pain, and then the central nervous system panics and tells the pelvic muscles to clench even harder to protect the area. The cycle constantly feeds itself.
It is a devastating, self-perpetuating feedback loop, and it clearly illustrates why treating this condition with a single approach is fundamentally flawed.
So how do we intervene? How do you actually break a cycle that is this physically and neurologically entrenched?
We must address both ends of the spectrum, starting with the gold standard for the dermatological side. The absolute first-line treatment for lichen sclerosus is ultra-potent topical corticosteroids.
Specifically, ointments like clobetasol propionate, right?
Yeah, clobetasol. This is not optional. It is a clinical necessity.
Because it stops the immune system from destroying the extracellular matrix protein 1.
Correct. The steroid suppresses that localized T cell response, halts the aggressive inflammation, stops the tissues from fusing together, and crucially prevents the small but very real risk of the chronic inflammation progressing into squamous cell carcinoma, which is a form of skin cancer.
So the steroid puts a fire out on the surface. But, as we've established, steroids do absolutely nothing for the hypertonic muscles underneath.
Not a thing.
You can't rub a topical ointment onto a deep systemic muscle spasm. And here is where patients often run into some deeply ingrained but dangerous medical advice. The traditional reflexive advice for anyone, especially women, experiencing pelvic floor issues or incontinence is
Just do your Kegels?
do your Kegels.
There.
The sources threw up a massive red flag here. Traditional Kegel exercises are heavily contraindicated for someone with a hypertonic pelvic floor secondary to lichen sclerosus. Why is that specific exercise so harmful in this context?
Well, because a Kegel is a concentric contraction. It is an exercise where you are actively tightening and shortening the muscle fibers to build strength. Think about the physiology of the problem we just discussed. The pelvic floor is locked in a guarding spasm. It is exhausted, depleted of oxygen, and full of lactic acid.
Yeah, it's barely hanging on.
Exactly. If a patient comes to a clinic with a calf muscle that is locked in an agonizing Charlie horse, you would never tell them to go run a sprint to fix it.
You would be forcing an already clamped muscle to clamp even harder.
It drives the muscle into complete failure. Telling a patient with a hypertonic guarding pelvic floor to do Kegels will dramatically exacerbate their pelvic pain, increase the muscular tension, and actually worsen their incontinence.
So if strengthening is off the table, what is the actual mechanism to break the muscular side of this cycle? This is where pelvic floor physical therapy, or PFPT, steps in.
Right.
Reading through the patient advocacy resources, it is clear that specialized physical therapists are the crucial bridge here.
They absolutely are. A trained pelvic floor physical therapist shifts the focus entirely away from strength and focuses on tone, coordination, and tissue elasticity.
The sources outline a few primary techniques they use, starting with reverse Kegels and biofeedback.
Yeah, so this is fundamentally about neurological retraining. The patient's central nervous system has lost the brain-body connection required to let that muscular hammock go slack.
Because it's been guarding for so long.
Right. Through biofeedback, which often involves placing small external sensors on the perineum that connect to a monitor, the patient can physically see their muscle tension on a screen. The therapist teaches them how to consciously locate those muscles and, more importantly, how to drop them.
And a reverse Kegel isn't pushing down or straining, is it?
No, not all. It's learning how to consciously lengthen the muscles back to a resting state, reteaching the nervous system that the thread is gone and it's safe to turn the alarm bells off.
It quiets the sympathetic nervous system.
Exactly.
And then there is the manual intervention, myofascial release. This part of the clinical overview is genuinely fascinating. We talked earlier about the severe architectural scarring of LS, how the skin can fuse, causing clitoral phimosis. It sounds so permanent. But pelvic PTs use specialized soft tissue massage to address this. How does applying pressure to scar tissue actually help?
It comes down to the nature of fascia and connective tissue. Fascia is a continuous web of tissue that wraps around every muscle and organ. When it is inflamed or scarred, the collagen fibers clump together, becoming rigid and fibrotic.
Right.
But fascia responds dynamically to sustained, gentle mechanical load.
So the physical therapist is physically remodeling the tissue.
Yes. By applying highly specific, sustained manual pressure myofascial release, the therapist creates gentle friction and heat. This physically breaks up the adhesions. It's called a piezoelectric effect, where the mechanical pressure literally changes the tissue state from a rigid solid back into a more pliable, gel-like state.
Wow.
They can actually help unfuse clitoral adhesions manually, restoring mobility without surgery.
And by breaking up that rigid scar tissue, you are allowing blood vessels that were squeezed shut to open back up, restoring microcirculation to tissue that was starving for oxygen.
Which is exactly what the tissue needs to heal. And this manual therapy is often paired with the third major tool, which is dilator therapy. Lichen sclerosus often causes introital stenosis, which is a severe narrowing and loss of elasticity at the opening of the vagina. Penetration of any kind becomes impossible or highly traumatic.
And if a patient tries to just push through that pain, the brain panics and the hypertonic muscles clamp down even harder.
Exactly. So the physical therapist guides the patient through using medical dilators. They start incredibly small, working strictly at the patient's own pace. The goal isn't just stretching, It is desensitization.
That neurological component again.
Right. It is safely and gradually restoring the elasticity of the tissue while simultaneously teaching the nervous system that penetration does not have to equal pain. It allows the patient to reclaim their anatomy in a safe, controlled environment.
It is a completely different paradigm of care than just prescribing a steroid cream and sending someone on their way.
It really is. It is the gold standard of multidisciplinary care.
So what does this all mean? We started this deep dive looking at a surface-level autoimmune skin condition. We examined the immune system misfiring, the white plaques, the intense itch. And we discovered how that surface trauma triggers a massive, deep, systemic muscular defense mechanism that can completely derail a person's quality of life.
It's all connected.
We learned that you cannot effectively treat a localized symptom without addressing the entire system that is reacting to it. Whether you are a medical professional, a patient currently navigating these muddy diagnostic waters, or just someone fascinated by human physiology, the big takeaway is respecting the profound link between the mind, the skin, and the muscle. Pain is never just localized. The body always keeps the score.
If we connect this to the bigger picture, it underscores a necessary shift in modern medicine. The human body does not operate in isolated departmental silos. Multidisciplinary care, where a dermatologist managing the immune response works directly alongside a pelvic floor physical therapist managing the neuromuscular response, is not a luxury.
No.
It is an absolute necessity for complex overlapping conditions. You simply cannot dismantle a vicious cycle by only treating half of it.
We've spent this time exploring how intensely our deep pelvic muscles will subconsciously clench, hold on to trauma, and completely exhaust themselves, simply to protect us from surface pain, or even just the anxiety of anticipating that pain. It really makes you wonder, if you're listening to this right now, what other invisible muscular compensations and tension are you carrying around in your own body, completely unaware, just because your nervous system is working overtime to protect you from something else?
That is a profound question to end on.
Until next time, keep questioning the X-rays.